Can I invite Dr. Viraj to present his case?
So, good afternoon, everyone. I am Dr. Viraj, practicing as an upper limb and sports surgeon at Max Hospital, Saket. At the outset, I would like to thank Master Case Series team to provide me an opportunity to present at such a prestigious state. So, we all do ACL reconstructions very frequently. But I was one of the unfortunate ones to encounter this case scenario wherein the femoral suspensory button fixation got jammed in the femoral tunnel. So the case scenario is that we had a 50-year-old lady. She's a homemaker. She presented to us with left knee instability after a twisting injury. She had near full range of motion. Lachman and anterior drawer of grade 2 laxity with grade 1 pivot. The McMurray and valgus varus stress were negative. She had an active SLRT of 90 degrees and an intact distal neurovascular status. So we investigated further. The MRI of a left knee showed complete ACL tear and no evidence of meniscus tear. The cartilage otherwise was normal. So at 50 years, the decision making is always very dicey. So you get the alignment x-rays, you get all the other issues, you ask the activity levels, and then you choose whether you want to conservatively manage or you want to go for operative management. So these are the parameters that we usually choose, depending on what is the age, depending on how disabling is the symptoms, any comorbidities, or what are the activity expectations. So this was performed by one of my team members. So he ended up doing left knee routine arthroscopic ACL reconstruction with a ipsilateral hamstring graft. This was the intra-op picture, and the graft diameter was 8 millimeters. The femoral tunnel length was 30 millimeters, and the femoral socket was drilled at 26 millimeters in the femur. Now she was a short-statured lady, so we thought, okay, the 30 millimeter tunnel might not be non-anatomical, considering sometimes that the stature of the short stature can contribute to that. The femoral fixation was done with adjustable loop endo button and a tibial fixation with a bioscrew. And then the patient was shifted to the ward. Then it is a routine procedure for us to get a post-op radiograph. So this is what we found the next day in the morning. So the femoral button has moved in its position and it has gotten stuck in the femoral tunnel. So what do we do next? So this is my ARS question. You accept this radiograph and discharge the patient with a knee brace. You inform the patient about the current condition and the need to intervene immediately. Or you inform the patient about the current condition and reassure that no active intervention at present needs to be done. Okay, so even we concurred with the same thought process. There is no point that you are going to put a knee brace and discharge this patient. And the only consideration was, the thought process that we had was, sometimes, is it acceptable because the button is stuck in the tunnel? Does it provide any relative stability that if at all she comes up with instability later on, we might revise? But that was not the thought process that we thought. We said, okay, we counsel the patient for an immediate intervention, and then we consented for the harvesting of the opposite side hamstring graft, and we arranged for the instrumentation and the inventory. So the operative planning, this is what we thought. We would first go and perform a diagnostic arthroscopy prior to harvesting any of the new graft. So the first plan was try and get the button dislodged from the femoral tunnel, retrieve the graft in toto, use the same graft, and then maybe do an aperture fixation at both the femur and the tibia.
So how did you plan to retrieve the graft in toto?
That's what I'm coming, okay. I'll come down, sir. So the plan B was, what if the button doesn't get dislodged? then if the length of the graft in the femoral tunnel is still okay, we can still go, is the length enough for us to just put in an in situ aperture fixation without trying to dislodge the button. The third plan was if the button is not getting dislodged and the graft length is not that great, then we have to take down the graft and just do a revision ACL. So when we went in,
Excuse me. Okay.
yes.
So in your case, I think you have the advantage that the tunnel positioning was too posterior. So you could have made a totally different tunnel. If you are trying to revise it, you can go ahead and do a totally different ACL reconstruction. So that was a strong point in favor of your case if you are trying to revise it.
Yeah. So what we ended up doing was we went in. When we did the diagnostic arthroscopy, the graft was lax and bunched up. Now the important point here is that the mouth of the tunnel is still covered with the graft. It's not like, even though the adjustable loop button was used, the graft has just slid down and then the button has gotten stuck, but then the mouth of the femoral tunnel is still covered with the graft. So what did we do is we used these two commonly used instrumentation in our OT armamentarium. The guide wire that we use for the interference screw and the slotted cannula that you use for your routine meniscus repair. So we went in. The problem was every time you try to use the guide wire to dislodge the button, the mouth is still covered with the graft. So you need something like a retractor to pull the graft away and then try to dislodge. Otherwise, you'll just continuously poke in through the graft and you'll just waste the graft material. So what we did, we introduced the slotted meniscus cannula onto the aperture of the femoral tunnel and then used it as a sleeve over which you pass the guide wire. So we were able to overcome and negate the graft, pulling it to one side and pushing the guide wire in, and using repeated manipulations and a CM guidance, we were able to dislodge it from the femoral tunnel. Now, before we ended up doing this, we actually removed the tibial screw and tried to pull it. Sometimes, if it is not stuck in the tunnel, it might just come out, but it was not the case. It got stuck in the femoral tunnel. That's why we had to use the guide wire to manipulate the endo button.
No, my thing was that even if you remove the tibial screw, because the graft is inside the tibia, how are you going to hold it?
So the thing was, we had enough graft that was still outside where we could still retrieve it. The wires, the ethibond was not all the way inside. So we had good length of the graft. And then once the endo button got dislodged, under CM guidance, we were able to pull the whole of the graft with the endo button out. And this was the CM image that showed that we were able to remove the whole thing out, and the graft was still otherwise okay in terms of length. So once we did a relook after the graft came out, we realized that the lateral wall had a partial blowout. So we went and did a routine redo ACL fixation, and we put aperture fixation at the femur and the tibia. And this was the post-op X-ray that we did. Yes, sir. We use the same graft. We just use the screws in the femur and the tibia. Now, the most common cause, what we always think, the moment the button is inside the femoral tunnel, there are only two questions. Did the button flip in the first place, or after flipping has it migrated inside the tunnel? So, if the button has flipped out, if the button has already flipped beyond the femoral cortex, the only explanation is that the lateral wall has blown out. And when we went in and rechecked our OT notes and consulted the concerned surgeon, so he admitted to it that when we usually want about 20-25 millimeters of graft inside the tunnel. Because the tunnel was small, the actual femoral diameter tunnel was only 30 millimeters. An inadvertent making the tunnel bigger in length to get more graft inside, he ended up drilling it up till the 26 millimeter socket. So we only had 4 millimeter of lateral femoral cortex that was there. Remember that this is a, this is a 50-year-old lady. So the lateral wall blowout, the most common cause, what we realized was the lateral cortical support was less than 5 millimeters. It's a 50-year-old lady. You don't know what is the, it is very difficult to assess the quality of the bone. And sometimes we've seen this, that if you cycle the graft, so you end up holding on to the end of the tibial side of the graft and try to vigorously cycle. Sometimes in a weak bone, this might be a cause for lateral wall blowout, in especially patients who have very weak lateral femoral cortex. Now, if the button has not flipped at all, the other options obviously is because of the wrong markings on the graft, or sometimes the utilization of the right kind of implant. So we used ACL tightrope RT. Now the difference between RT and RTJ is that they have an extra fiber wire on the end of the loop, wherein it gives us the tactile feedback of the fact that the buttons flipped on the cortex. So unfortunately, we didn't use the RTJ or RT2 as it is said. And I think one of the pertinent thing that we realized was, if unsure about whether the buttons flipped or no, there's no shame in just taking a C-arm shot and confirming it in the first place.
Yeah, Viraj, we have one question.
Yeah, for me, I don't quite understand why people do an X-ray after the operation in the ward. I mean, if you're so concerned about something, what's the point of doing the X-ray the next day? Why don't you do it in the theatre and check the buttons flip? That's number one. And number two, if you really want to check if the buttons flip, then just take your scope and look up the lateral gutter and actually check that the buttons flipped in every case, because often these buttons get caught up in the soft tissues, and then you have it sort of caught in the soft tissues, and it's so easy to just look up the lateral gut and make sure that it's sitting flush on the bone. But it just doesn't make sense to me to do an X-ray afterwards. You might as well do an X-ray intra-op if you're worried about it.
I completely agree with you, sir. That's where we changed certain protocols later on after we burnt our fingers. And
I think 15 mm graft is enough for femoral tunnel here.
yes, sir.
Why you want to go up to 25, 26?
That's one of the things that we realize, that sometimes the minimum basic graft that you want in the tunnel is 15 mm. But sometimes you want more graft inside the femur. That is what led it.
But
yes.
the healing is only at the aperture, not
Yes.
in the tunnel.
Yes. So that is what we realized later on. So the learnings from this case was, sometimes in a short statured female with osteoporosis, postmenopausal woman, 50 years, aperture fixation might not be a bad option going up in the first case as well, rather than relying on the suspensory fixation. It is important to know the implant differences, RT versus RTJ, wherein you get the tactile feel of the button being flipped. Sometimes a simple instrumentation like a slotted cannula and guide wire might be useful in the way you use it to try and dislodge the endo button. And this is one of the things that we added on in our protocol after this case, is that we started using intra-op C-arm imaging just to make sure that the button is flipped on the femoral cortex. And I think with a lot of activity-driven middle-aged women, incidence of ACLs are getting increased, and it is pertinent for us to evaluate for osteoporosis, because sometimes we might be really surprised by the quality of bone that eventually we get, and that is something that is not in the surgeon's capacity. Thank you.
Yes, Amit.
Yeah, thank you very much. Very well executed, but you won't be so much lucky all the time, because getting that button which is stuck into the femoral tunnel just by a flimsy, the nitidol wire is sometimes really difficult. It's not, you are lucky in this time. But what important I would like to say, rather than changing your protocol and using C-arm on each and every case, I think measurement of the tunnel and adequate marking of the graft is very, very essential. If you would have marked adequately or appropriately into the graft, and you feel that either your graft is going too in or your graft is still too out, then you are in suspicion that either you have pulled it more or your button has not flipped into the lateral cortex. In that case only, if you are in doubt, your grafts are not fitting according to the marking, then you can use your whatever CM or whatever devices to, just rather than doing in each and every case doing a CM which is not justified.
So just to make a point on that, I showed the intraop image after the graft was fixed in the first case. The markings were probably intact, and this is just to highlight that in my case it might not have been the case where it was wrong markings. Probably the lateral wall blowout was what caused the button to get stuck inside the femoral tunnel, and not the other way around where the button hadn't flipped in the first place.
Just a really quick point, really lovely case. It's something I worry about all the time. A top tip with these RT tightropes, what you can actually do is you can lengthen the tightrope, you view from the medial side, and you can actually see the button go through your hole. That way you know that the button is actually flipped on the lateral wall and not gone beyond the ITB. And then you can also tell that you haven't blown out the lateral cortex as well. But I always lengthen the button, pull it through, and under direct vision, then you don't need X-ray or anything else.
Right.
Good case.
I completely agree that I think this button was nicely flipped at the first instance, and later on during the cycling or during physiotherapy it blown out. And it can happen not only in old age bone, I think it can happen in when we do early surgeries where the bones become weak, So many cases you are lucky you discovered it early. What we find, I personally do not do routine X-rays, and I have some cases, I have found those after about a month or two. And at that time, I just let it go and patients are doing well. So my question is, it's very interesting you have used same graft and that graft has remained in the body for about 2 to 3 days.
No sir, this is just immediate post-op. So
immediate post-op. So my question to all the seniors, how long, for example, we found out this thing after about 5 days, can we still use that graft, or we have to, if we want to revise, if any options, any opinion?
I'm sharing one of my experience. I have operated a case of 150 kg patient, and he is having PCL, ACL and MCL, all 3 ligament. I operated all the things in same fitting, but after a month, the patient presented to us, and then we found that the button which has been flipped is now into the tunnel for the PCL. Why? Because the patient is not wearing brace, he is very adamant. So in those kind of the scenario, after 1 month, what we did, we just take out the button from the tunnel. We didn't take out the graft from the tibia side. So the graft was intra-articular and the button was in the tunnel. So we just remove the button and then take out the button from the port, then just pass 2 fiber tape from that, and then just we used to pass our graft or the button from the femoral tunnel. In the same way we pass it through that, and then we place one extra suture post on the femoral button and use the same graft, and along with that I use the aperture fixation on the femoral side for the double security. The size of the patient was so bulky that the cortical screw are not of that length for that post on the femur, so we have to use even the 4.5 mm locking screw, because the length of that cortical screw was somewhere around 90 mm.
To answer your question, Vivek, I mean, if we look at literature, the upper limit probably would be 7 to 10 days. After that, all the tenocytes undergo lysis and it's just a scaffold that is left behind.